So I want to talk basically about what we've done over the last few years to maximise the amount of organs that we can give to young children. So to give you a bit of background, I'm a senior paediatric perfusionist here at Great Ormond Street Hospital in London, and I do that sort of part-time, and the rest of the time I spend in research. I'm a honorary research fellow at the Institute of Cardiovascular Science, which is part of University College London, and I'm funded by the British Heart Foundation. So other than that, I have no disclosures to make. I want to start by giving a bit of a state of the nation address about what's going on in the UK in terms of transplants. And what we have is essentially two paediatric transplant centres here in the UK, ourselves and the team up in Newcastle. And if you look at the last sort of year or so's data, what we see is despite COVID-19, the number of transplants we've had has been fairly stable across the two centres themselves. But what that does is actually mask the fact that we are now having record numbers of patients waiting for transplants here in the UK. And what that means is actually, if you look at the waiting times for those patients, they're going up. So even fairly seriously ill young children are waiting well in excess of a year for a heart to become available. And even for those that are urgent, you're still waiting over 3 months, which is never great when you're young and you're in severe heart failure. So to state the obvious then, we simply don't have enough hearts to go around in this country. Now, one of the ways that we looked at dealing with this, and it was looked at many years ago, back in the late 90s, early 2000s, was the concept of incompatible heart transplantation. And what the idea with this was, is on our cells, we have antigens that essentially distinguish ourselves, so self and non-self cells. And these particular items that we're interested in are isohemagglutinins. And whilst group AB patients will never develop the antibodies that attack these antigens, for the rest of us, these tend to build up over the first few years of life. Now, back in the late 90s, early 2000s, Professor Laurie West and their team for the Hospital for Sick Children in Toronto, Canada, looked at this and discovered that actually, up to about the age of 12 to 14 months, these antibodies that can cause rejection are at such a low level that actually they're not really an issue. And actually, there might be a way of convincing the body's immune system that actually an incompatible heart can become compatible. And so what they did is undertook the first series of incompatible heart transplants in this group, and it had phenomenal impact. It reduced not only waiting lists, but waiting list mortalities by around 50%. So massive, massive impact. And since that time, our understanding of the immune system maturation has improved dramatically. And in the last 20 years, we've now developed this technique all over the world, up to 8 patients of around the age of 4 years old, or 15 to 16 kilograms. Now, it's not just a case of put any heart into any recipient. It doesn't often work that way. And the way they developed to get around the immune system was by using a 3-fold plasma exchange process. And so what this did was minimize the risk of hyperacute rejection by simultaneously removing the patient's native circulating volume via the venous line and then discarding, and at the same time replacing it by 3 times the patient's circulating volume in donated blood and fresh frozen plasma. There were many issues with this process, despite the fact that it worked. The first being that there was a vast quantity of donated blood and plasma that was needed in order to actually minimize the risk of hyperacute rejection. And this could actually run into litres for children up to age about 4 years old. And this meant that actually, as a physical limitation, we couldn't do any children over that age. And the other problem was that this plasma exchange process had to be done prior to initiation of full bypass in order to get a good plasma exchange. And so we had to rely on the recipient's failing heart in many cases to support them whilst this process was being undertaken. It took about half an hour. The issues with this is, of course, if you have to then crash on to provide any support, these children would get, what's the word I'm looking for, a less than perfect plasma exchange process, which meant that the risk of hyperacute rejection would be not minimized simply because you had these isohemagglutinins still present in the bloodstream. What is interesting is actually, if you look around the world in who is available and, what recipients can actually undergo an ABO compatible plasma exchange process or even a mismatched heart transplant. It varies from country to country. In the UK, we generally worked on the idea that anybody under the age of 4 years old, and in the region of 1 in 16 to 1 in 32 digest for antibodies. In Canada, it was a bit more lenient in terms of it was down to the individual clinician, who would obviously be familiar with the recipient, how long they've waited for a heart, what the likelihood of them getting another heart within a reasonable time frame was. So they had a little bit more flexibility. Whereas actually in the USA as a whole, it was very, very strict and actually was only allowed in patients up to about 2 years old and with a very, very low titer. Although back in March 2015, they were discussing actually relaxing this to be more in line with Canada or even in the UK. I don't think, as far as I'm aware, this has actually happened yet, but there's still time. So despite all the limitations of the plasma exchange process, we know that it works, and it's been actually very, very successful for many years. And it's shown equivalence in survival with those of compatible heart transplantation time. But with all this, we thought there was probably a better way to do this. This wasn't the optimal way that this would be able to go forward. And so back in 2014, we started investigating the idea of replacing the plasma exchange process with the method of immunoabsorption. So immunoabsorption targets the actual antibodies themselves. So it doesn't require the removal of any plasma. It simply acts to remove the antibodies themselves. And it's normally done using multiple treatments in the run-up to transplantation. It's often quite common in kidney transplantation, for example. And this, of course, works because the dates of transplantation is set and planned well in advance. If there are any issues, you can delay, repeat the process, and keep going. Now, obviously, this isn't necessarily the case with cardiac transplantation. As many of you who actually get involved in this will know, generally you have about 12 hours from when they tell you you've got a transplant to when the organ is being reperfused in the recipient's body. So in a normal situation, immunoabsorption isn't really designed to be used in this situation where you have no time really to perform this technique before actually using it, and with a very short timeline. And the other issue is that you can't just give this treatment to anybody in the run-up to transplant when you don't know when that transplant is. What normally happens is if you were to remove these antibodies, they will come back over time, and you would need some form of immunosuppressive therapy in the pre-transplant period to prevent the isohemagglutinin reoccurring. And of course, this leads to other problems in terms of infection and other risks that you really want to minimize. So what we decided to do in this case was then say, well, why can't we actually then incorporate it as part of the bypass process itself? Just use it instead of the plasma exchange process. So what we did was we mocked up in a laboratory setting a circuit that we would normally use for a bypass, but we incorporated a plasma separator, and essentially were able to spur off from the arterial circulation, remove the plasma, from which we then could remove these antibodies, then recombine the antibody depleted plasma with the red cells that been separated earlier, meaning that you got antibody depleted whole blood put back into the systemic circulation. And this could then run throughout the bypass case, with the idea being that by the time you took the cross clamp off and reperfused the donor organ, you would then find that the number of antibodies had been reduced to a safe level. And I should at this point pay homage to my ex-colleague David McGarry, who very kindly walked in one day with a load of coffees and pastries and donuts and said, hi, how is everybody? And we asked him what blood group he was, sat him in a chair, stabbed him in the ear, took a load of blood off him, gave him a cup of tea and sent him home again. But what this allowed us to do, because he was a group O donor, was to take his anti-A and anti-B antibodies and basically create a mock circuit from which we could then pretend that we had a typical child undergoing ABO-incompatible heart transplantation, and then use this to and augment it with fresh frozen plasma to increase the number of antibodies we had, to create essentially an ex vivo model of what we would hope to do in reality. And what this allowed us to do is to actually work out the exact amounts of fluids we would need, what the patient's circulating fluids would be, take this all into account, know the rate at which we needed to treat the plasma volume, and then go ahead and treat it. And as you can see, this was done when I was slightly younger and my eyesight wasn't quite so bad. What we did was use fluorescence activated cell sorting. So what you're trying to do is look at the IgG on the left and the IgM on the right. And over the period of time, is look how much of that actually binds to the antibody. And so you get this decay occurring in fluorescence, meaning that actually there is less IgG or IgM, whichever case it might be, to actually then bind the antibodies. And what this allowed us to do is actually see that through a sequential plasma exchange treatment, you saw this decrease in the number of antibodies that were actually available to bind. And we actually saw this when we repeated it with the ELISA analysis. So hemagglutination, essentially, is the way this works. And what this allowed us to do is essentially validate the other method. And in summary, essentially what we were able to see is that with every plasma volume that we put through the immunoabsorption column, you got at least one titer drop from your baseline. So we could then have a way to say, right, this patient has a 1 in 32 starting titer, therefore we need to do 5 plasma volumes in order to bring that under a safe level where we're not worried about rejection at all. And so this is what it looks like in reality. And you can see the plasma, the immunoabsorption column put here. We published this paper then back in 2018 with the first case report that we did in a child. And what we found was actually that the predictive nature of what we were doing really allowed us to create this ready reckoner, as I referred to earlier, where we could actually now start planning what patients we could take and use this as an example of taking the data and using it for patient and recipient matching. And what we then thought was actually, because we've done this, because we've removed this need for a vast quantity of blood from plasma exchange, which was predominantly the limiting factors in what size of patient we could actually treat, we then started to think, well, could we push this a little bit further? Could we actually start using this in patients above the typical 4-year-old cutoff? And actually, when we published this paper, we were quite honoured to actually receive an editorial that accompanied it. And whilst it was very supportive, it raised sort of 4 main questions to basically say, yes, this works, but how safe can it be? How much can we push these boundaries? And what they currently asked was, if you're going to increase the size of patients, are you also able to do that whilst decreasing the amount of blood? Because the two don't often go hand in hand. More significantly, we know that the ABO incompatible method with plasma exchange is equivalent to survival in compatible heart transplantation. So anything that you do has to be as good as that and as good as compatible heart transplantation, otherwise it's not going to work. And also, we don't know what effect this would have longer term in terms of antibody reaccumulation over time, or whether there's going to be an increased risk of rejection. We didn't believe so, but we had to prove it. And so what we did then was look at all the transplants that we have done over the last 20 years, so between January 2000 and June 2020. And we were predominantly looking at whether or not we could actually decrease the amount of blood uses, and also whether we could attain what we call non-inferiority. So is it going to be as good as the methods that we currently use? So what we did was essentially use our electronic patient record, and we have at GOSH something called the digital research environment, for which I'm a clinical lead. And that allows us to go in and use open source tools to essentially take out whatever information that we want to do. So in particular, we looked at sort of the demographic data, the ward stays, biopsy results, laboratory settings in terms of the hemagglutinin counts, and any and every data we could get hold of, essentially. And we were quite privileged to get this paper published a couple of years ago. Again, looking at our case series, the first 10 patients that we used over the 5-year follow-up. And if you want to know a bit more about it in a bit more detail, we actually got involved in doing the podcast from the November edition of the Journal of Heart and Transplantation, which talk to the editor about what the results mean, long impact. So we actually have a look at the patients themselves. The first thing you'll notice is actually the age of the patients we were dealing with was, most of them were actually over the 4-year sort of cutoff, the traditional limit to what we were able to do with ABO and coronal heart transplantation. That's the sort of first thing of note. And the second part is that actually, as with all ABO and coronal heart transplants, you're actually predominantly positively discriminating against patients with a O blood group, because obviously these are the ones that often get left behind because they're the organs that would normally fit them tend to go to either the AB or AB groups. And finally, if you look at the pre-transplant support for these patients, it's very interesting to note that over 7 out of the 10 of them were on some form of support, whether it be VAD or ECMO, immediately prior to bone transplantation. So it gives you some idea about how sick these patients actually were. If you actually compared the group, so looking at those patients that had the immunoabsorption with those patients that had plasma exchange, one of the things you need to notice is that they are significantly older patients than we were traditionally able to do. What's also interesting is actually, although it didn't reach significance, probably because of the small population, these patients were sicker patients. They were all on artificial support, as I said before. And whilst we talk about the data in terms of what it says, it's easier sometimes to actually see this visualization about what this has done to the age range of patients we can treat. So the grey area at the bottom is the compatible transplants, which, as you can imagine, we see across all ranges of ages. The yellow is the traditional ABO compatible group, which is obviously treated with transplants with a plasma exchange donor. And then the blue area is what we're able to do now with the plasma, with the immunoabsorption column. And you can see that we've spread out across that area. We still have that peak of patients that are very young at about 8 to 9 months, but we're able to push this up to over 8 years old. If you look at the interrupted data, the first thing that jumps out of you is the fact that actually it takes longer to do this process. That's not strictly true. One of the problems with the plasma exchange process is obviously it takes place before you actually start bypass. So half an hour of being connected to the patient in terms of cannulation and the plasma exchange process going ahead isn't actually taken into account. And when you do take it into account, actually there is no difference. But it's not classed as bypass, so it's typical statistics flipping the figures. But more importantly is actually that we managed to halve the amount of blood that we're using. So this is a massive change from what we're able to do. And whilst this may not be particularly surprising, because I've just told you that we use a lot of blood and blood products with the plasma exchange process and taking that out. What is interesting is when I did a sub-analysis, so essentially excluded any blood that was given as part of the plasma exchange process itself. If you looked at the post-op usage, actually what we found is half the amount of blood use is there. And the reason we think for this, and it's something that's been put forward by a number of people, is actually that transfusions beget transfusions. When we give blood, plasma, and cryoprecipitate, whatever it might be, we never get the exact proportions right, no matter how hard we try. And what we give back will never be what the patient needs, no matter how good we are at this. And so often they're going to need more products in the post-operative period. So we're not only affecting what's happening in the theatre setting, but also what is going to happen in the post-operative setting as well. Now, when you look at the antibody reaccumulation or the antibody reduction, depending on how you look at it, obviously this is key for allowing this to go through without having massive impact in terms of rejection. And one of the things that we looked at was the whole profile of the immunoabsorption and the isohemagglutinin in production. So whereas quite often when you see something quoted about what the patient's titer was, this would be immediately pre-transplant. Now titers tend to vary across the years or months depending on how long the patients are monitored for. And so what you get is a very different value compared to what the actual maturity of the immune system is. So I used what they call a mixed models method. So looked across the whole time frame and actually took the highest point pre-transplant as an indication of the transplant, the immune system maturity, and then compared that into the sort of early and late post-transplant phase. So you're looking at sort of within 6 months and up to sort of 3 years afterwards. And what we saw is actually in the preoperative setting, most of the time, actually, it was very, very similar in terms of titers. But actually, a lot of the older patients had a significantly higher anti-B maturity. But actually, there was no significant differences in the post-op values. And actually, we didn't see any reaccumulation in isohemagglutinins with immunoabsorption, whereas we had done in the past with the plasma exchange process. And what's more, in the follow-up period, where we had actually seen, within this time frame, where we'd actually seen a evidence of acute and cellular rejection, antibody-mediated cellular rejection in the plasma exchange group, we didn't see any in this immunoabsorption group, which obviously gives us another avenue of investigation. Why are these patients not seeing anything? Is it just the effect of removing all the antibodies, or is there something else that is becoming out as part of this process? And then finally, when we looked at the idea of survival, so, are we making sure that what we're doing now is as good as what we had beforehand? We noticed that actually, when we compared the groups, and I used a statistical test known as the Peter weighting, so it puts more weight onto very early differences between the groups. We found there was no significant differences, and there was no deaths in the immunoabsorption group, and no need for retransplantation or reinterventions in this particular group. One of the things that we were very keen to make sure that we adjusted for is the idea of age. Obviously, when you've got a smaller and a younger plasma exchange group, we didn't want those to be adversely affected purely on the basis of age. So I used a proportional Hounson's regression to see the effect of age on this. And actually what we found, which is quite surprising, was that the opposite was true. Actually being younger was a benefit. The older you are, the higher the risk of death at the point of transplantation. And so despite that, we still did not see any damage effects, as it were, of using the immunoabsorption group. So in essence, to answer the questions that we had before of the editorial was, can we actually use these larger, these devices to enlarge the group of patients that we have? And yes, we can do. We've doubled the age range of patients we're able to do. I think the eldest patient that we've done so far is 9 now. And what we've managed to do that at the same time as, halving the amount of blood and blood products that we have to use, not only in the theatre setting, but also in the post-transplant and ICU setting, which is quite remarkable, really. There's also no evidence that we have tighter reaccumulation of the isohemagglutinins, and no evidence of any sort of cellular rejection or antibody-mediated rejection within the same time frame that we have seen it before. And there's no inferiority in terms of that rejection episodes or actually the survival itself. So from our point of view, it's been a massive success, and we're very happy with it, and it's actually been developed a bit more now. Now, obviously, this is what data says, and it's all very nice looking at graphs, but hopefully what I'll be able to do is put this more in context and give this more of a human element. So what does it really mean? Well, I'll give you an example. This is Lucy. She was a young lady that was born with a rare form of restrictive cardiomyopathy that was picked up at 18 months of age. She was then placed onto the transplant waiting list when she turned 4. And because of her size and because of her physiology, she could only take a donor that was twice her size. And so because of this, she ended up on the waiting list for 3.5 years. During that time, as you can probably see, the quality of life that she had was incredibly poor. Her heart failure was fairly severe. She couldn't even walk from her car into the school playground and go into her own classroom without assistance of the wheelchair. She couldn't join in any sort of physical education or children's parties, anything like that. That if you're a parent like me, you kind of take for granted these very simple things. And she was actually being discussed for a VAD implantation at the age of 8, when we actually got a phone call to say that the right size of donor had come up, but it was the wrong blood type. But because we were doing this technique, we decided that actually we should push this, what we can do, push the boundaries of what we can achieve to see if we could actually give this girl some hope. And this is Lucy 6 months after she had that transplant. And I think you'll agree that she's doing quite well. What was quite nice is that we managed to get her onto the television and into the newspapers, because she's the oldest patient in the world who's ever had an elective AVO incredible heart transplant. And, she's looking to make up for lost time. And in fact, is going climbing, I believe, in Italy, climbing mountains in Italy this year. So, good luck to her. And, whilst this is fantastic and it's great to see the positive impact that's had, what is really interesting is the impact that it's had on the family, and the fact that what it's done is essentially reduce their time of waiting. So I managed to actually look at the transplant lists and the waiting lists that we've had during the time that between when she actually got a transplant and when the next organ that would have occurred. And what we can say with some confidence is that we knocked off at least a year of her waiting list with using this technique. And if you'd taken into account the fact of her going on to a VAD, other people coming on and being super urgently listed, so knocking her down that order, that would have been a lot longer. What's great to see is actually now, having published this and got this out to the media, we've now got centres all across the globe that are using this technique and are moving towards this technique. To the point that we have had another centre up in Sweden who have done their first transplant, and a centre in Spain who have now done a lung transplant using this technique. And more people are coming on board with doing it because they feel that this is going to be the gold standard of how we treat these patients for an AVO-compatible heart transplant. And ultimately what this means is that, across the globe, there's going to be many more children who get a chance of a heart far quicker, and when they're in a better condition than they would do if we were to wait for a compatible organ to come across. So hopefully we'll see many more great outcomes. So this is Lucy, now turned 10. So thank you very much for listening.